Okay, do you want to get everyone in then, Sarah? That'd be great, thank you. Well, welcome members of the public. Lovely to see you all again virtually today for this George Eliot October board meeting. We've had a busy workshop covering a range of topics, but in particular focusing on our plans on staff availability, bed availability and waiting times, the real practical issues which I know members of the public will be concerned about as well, given recent press reports. We had an excellent day last week as a board at a strategy away day, and we were building on that again this morning. So lots of stuff happening, but delighted to see so many of you joining us today. So I think we are quiet. The only apologies we have is from Rosie, I think, which will be duly noted. So the last set of minutes of the meeting held on the 6th of September, was everyone happy with the accuracy of those minutes? If you weren't, please raise a digital hand. I can't see any digital hands raised, so we'll take those as an accurate record. We'll move on then to matters arising, which are on page 21 of the pack. The first is to come back to us in December, which is about the CAS card to board. We'll come back to that in December, so thank you Catherine and Robin. We'll also come back in December on the changes arising from the National Patient Safety Incident Report Framework, although that has actually been done, but it's agendaed for the December board, which is slightly confusing.
Just to clarify, Russell, that's coming to the December board workshop for an update on how we are going to implement that in the organisation. Super,
thank you very much, Catherine, for that clarification. Also to come are the system finances going forward. We've obviously got updates today on our finances. The statement of cancelled operations to be included into the IPR. Thank you for doing that, Robin. Sarah to provide guidance on the new code of governance for NHS providers with the audit committee. That will be done once we've got the guidance. Thank you, Sarah. Then lots of changes to the dates of when things are going to be done. I know everyone's busy, but I don't like things slipping quite as much as they appear to be. Jenny to provide the board with an update once the sustainability survey has been undertaken. We've got the sustainability on the update on our board agenda today, but that's a different survey, so we'll come back to that in December. Hack to ensure the discussions held at the board workshop regarding productivity are included into the IPR. That will be done by December. The head of estates to arrange photographs of the just bear with. The newly refurbished League of Friends Cafe to be presented at the next board meeting. We're pending that, so looking forward to seeing some photographic evidence for all members of the public and to be able to see. Robin, where are we with that?
Yeah, Russell, the photographs have been taken this evening, the artwork's all finished, and the coffee shop is due to reopen on the 31st of October. Which is the timescale has been set by the training of the staff, the League of Friends staff, to reopen that. So that's the official dates as set today.
Well, maybe at the end of the meeting, it'd be great to hear from friends from the League of Friends about how they feel about the refurbishment. Thank you, Robin. Then Catherine and Gertie to ensure gender pay gap be given further consideration. That's on the board for today. Then Natalie to explore making the quality account more relevant, similar to the way the annual operational narrative plan was produced. We'll come back to that, won't we, Natalie? Thank you. Then metrics showing delays in mental health referrals could be added to the IPR. Thank you for doing that, Robin. Natalie to bring a visual back to board to show how the electronic ward dashboard looked and worked once live on wards. Coming back to that in December. Going to be a busy month in December. Can already tell that from the actions. Natalie to provide a more detailed analysis in regard to birth rate demographics in response to Councillor Condacord's question, which referred to how many new houses were being built. We'll come back to that by the end of the year. And I think that was it. So any questions arising from the matters arising out of those minutes? Please raise a digital hand. Okie dokie. Well, one of the things that was on that matters arising was a gender pay gap briefing note. Gertie, what would you like to pull out here for us, please?
I think the summary speaks for itself. Russ will have to take any comments or questions. This is a matter arising from when we presented the gender pay gap in June in my absence, and there was a query around the disparity between consultants, predominantly arising from Clinical Excellence Awards. They at the moment are being paid on a fair shares basis across all eligible consultants, and we're waiting for updated national guidance in terms of how they will continue moving forward. Happy to take any comments or questions, but we've included the action plan of the wider work we're doing to try and ensure that we're improving this position. Okay, great. Thank you, Gertie. Any questions from members of the board? Please raise a digital hand. Julie.
Thanks very much, Gertie. It's a good note and there's lots of things in hand. Just wanted to be clear how the board is going to receive regular updates about the evidence that what we're doing is making a difference. So I just wanted to record how we're going to do that. Yeah, this work sits under the EDI operational delivery group, the Equality, Diversity and Inclusion operational delivery group, which reports into the People Experience Transformation Board and then provides updates through that into the Quality Assurance Committee. So that will come through that route to board.
Okay, if we can make sure as the specific issue though, it reaches us every 6 months or so, Gertie, that would be good.
Absolutely, Chair.
Okay, Tim, we'll move on then to Glenn's report. Glenn, how are you seeing things?
Thank you, Chairman. Yeah, we had as you say, we had a good strategy discussion last week, which was quite timely because later on in that week we saw a few announcements from our new Secretary of State, Therese Kofi, and I set out some of those here in what was described as our plan for patients. I mean, that was produced very quickly after the new Prime Minister and new Cabinet were put in place. And as a consequence, there are a number of things within it that were kind of already planned for the NHS, but I'll pick out some of the new elements of this as I go through the report. I mean, the big statement, I think, was around this prioritisation of improving access to primary care, which has obviously been in response to concerns that have been raised. And it sets out a new expectation. It doesn't necessarily set out the workforce solution to those new expectations, but expectation that patients who will have an appointment within 2 weeks, that if it's urgent, they'll have a same-day appointment, and ability to contact practices. Interestingly, we have not seen statistics on the number of patients seen in primary care. So for the first time, we'll move to looking at the number of appointments available in primary care, and then reinforcing the fact that integrated care systems will be holding practices to account for that. Secretary of State sets out her priorities for the NHS in this ABCD, and it goes through ambulances and reiterates within that some of the pledges that were made in the winter plan that we discussed last month. Backlogs around the elective recovery plan, so the fact that we've got 7 million people now on NHS waiting lists. As I often say, the majority of which are actually not waiting for inpatient surgery, many are waiting for outpatient activity. And then through care, well, this is where there was a new announcement with £500 million being made available through an adult social care discharge fund. And whilst it hasn't been finally confirmed yet, we expect that to come through what's called the Better Care Fund, which is in effect money that the NHS passes over to social care to improve discharge. And we're trying to ensure that we have a really close grip on that. We have daily meetings where we discuss the number of medically fit for discharge patients with system colleagues, including social care colleagues, and trying to make sure that we we can improve those metrics over this winter will be a key consideration for us. And then finally, doctors and dentists, where, and indeed within the phraseology of this report, it talks about other disciplines, because the recruitment and retention issues go beyond just doctors and dentists, but some very specific pledges around improving access to NHS dentistry. We then had the workshop, and as I've described here, the three boards now have all met to look at a strategic refresh. And this is based on the fact that we set up what we call the strategic wheel, or the dartboard, sometimes referred to as, which is in the report there, a number of years ago now, and it's been a really good guiding light for us as we've moved forward, particularly as we've been more focused on prevention, on integration, on place. But it felt, particularly with integrated care systems been in place, that it was time now to just test whether it was still all valid for us. Having had all those three workshops now, I think we can confirm that the main essence of the strategy is still really relevant. But there's some areas that we discussed where we use this phrase big moves, some areas where we will need to do something particularly in our role as host or lead provider at place, to actually make sure that we resolve some of these challenges, and the challenges such as access to social care and the challenges of recruitment for domiciliary care staff. So we're working through those in the background. We will agree something, I'm sure now, having gone through those three workshops, that is broadly consistent across the three trusts in the group. There'll be local nuances and local things that are perhaps more important to one trust or another, but those will be captured in a revised set of strategic documents that will be available later in the year. And in all cases, they've also been fed by the views of stakeholders and also engagement with staff within the organisations. There's then an update on Women's and Children's Directorate, which starts with really sad news that Dr. Susie Matz sadly passed away in August. She was a great member of the team and really well liked by colleagues and patients. I also announce in here Lorraine Cardill, who's joined us as Director of Midwifery and Neonatal, which is a post which spans Swift and George Eliot and gives us strengthened strategic leadership in a really important clinical area. And then there's a piece in here on the reconfiguration of acute stroke services across Coventry and Warwickshire. Just pull out one element of this, and we're obviously supportive of this, and it's been something that's been a long time in the planning, is probably the best way to put it. We will be welcoming UHCW consultants to provide the consultant cover for our rehab ward, but it will still very much remain as part of the bed stock of George Eliot, and we will work across the system to ensure that patients get access to not only hospital bed-based rehab, but more importantly, early supported discharge rehab in the community. We will still be holding our medical division to account, and they will still be managing those services directly. And then finally, there's the usual list of staff engagement visits. So I'm happy to take any questions on any of those parts, Chair.
Thank you very much, Glenn. Any questions or perspectives to Glenn? Please raise a digital hand. Simone.
Thank you, Chair. I just wanted to note the comment about the difficult times in maternity and women and children's, and just to say how impressed I am with the commitment and the professionalism of that leadership team as they work through these issues. It's second to none.
No, I think that's really helpful, Simone, and a very important point to make. We are, and I have my maternity teams hear this, we're immensely proud of the work you do day in, day out to bring babies safely into the world. And we thank you on behalf of all of the population that we serve. Julie?
Thanks, Glenn. Again, a really full and helpful briefing report here. I just wanted, I suppose, to comment on the ambition about the priority for waiting time for 2 weeks for primary care. I'm very lucky. I get to speak to my doctor on the day that I ring up, and I'm not sure how ambitious 2 weeks is. That said, I'm not sure that the public really understand some of the difficulties around achieving even that, let alone something more ambitious. So my two questions really are, can ICBs set a more ambitious target around that locally? And the second one is just the communication locally around the priorities that the new Secretary of State has issued. Is we understand this, but do our local communities understand what's written in your report?
Great question, Julie. Glenn?
Yeah, great question. And we have not had an integrated care board meeting since this plan was published. So I'm sure the next meeting will spend a bit of time talking about, firstly, whether we think those targets go far enough, and then secondly, how we can communicate and engage with patients. I think the challenge, as I said when I went through the report, is that there are workforce gaps in primary care, there's workforce gaps in secondary care and in social care. So it's not easy to ensure the level of consistency that is needed to deliver these kinds of standards. And I think one of the things that the new Secretary of State has commented on is the variability of performance and access times across the NHS. And so there are elements, and sounds like you're well served by your practice. There are elements where these will be being delivered comfortably today, and there are areas where there's serious recruitment challenges, which make that really hard. I think there's also, though, as you imply, a really important part that the public can help to play with, because this choice about 2 weeks or today if it's urgent has to be a clinically based view rather than necessarily the pressure that an individual patient feels around their own level of urgency. And I still worry that when GPs quite rightly will say, actually, that's not urgent, you can have a 2-week appointment, and many of those patients decide for themselves that it's urgent and come to the front door of the hospital, come to either urgent treatment or A&E. And so trying to ensure that is negotiated with the patient and the patient understands it will help us, because obviously what we're trying to avoid here is patients using the wrong part of the system and causing us even more demand. So the public messaging on this is vital. As I say, we'll give some consideration to the targets and whether we go further, but we will need to ensure all elements actually of our winter plan are communicated to the public. One thing that we discussed this morning in workshop is the notion of home first being something that patients understand is best for them, not just us saying we haven't got beds or we can't admit patients. It's actually a safer place to be. So there's a lot to be done with the communities to get them to help to understand that that's the best way to deliver care. So I'll come back to you when we've had that ICB level discussion on this.
No, great, Glenn, thank you. I mean, it's enlightened self-interest for us to be working very closely with all the colleagues in primary care and secondary care to help them help us and help our citizens. I think the other danger is a dubbing down of standards over time. What we need to ensure is, at George Eliot, we're providing the very best of care at improving standards. And then finally, Sarah, then we need to move on.
I'll be brief. We don't have at the moment Warwickshire North specific details, but if any member of the public's interested, you can at the moment go on to NHS Digital and find out about Coventry and Warwickshire GP appointments. So in August, there were 439,000 appointments with GPs. Over half of them were face-to-face, with over 5,000 home visits. 44.6% of those were same-day appointments, and with only less than 15% being greater than 2 weeks from the time of booking. So we do have that level of information, which is really important for us as a system. But just in terms of the comment, Glenn, in the paper from the new Secretary of State, it does point to some of our other papers later about workforce issues, and we need to be really mindful as a system that we don't, to use the phrase, rob Peter to pay Paul, and primary care doesn't leach physios, nurse associates and others out into primary care. And also with the new, I think it was very high numbers of phone lines, 31,000 phone lines. Those phone lines, as we know, need to be staffed. And so locally, it would be nice to see local jobs for local people and people seeking employment in some of those non-clinical but really important parts of our that will make our system work and function effectively.
Points well made, Sarah, thank you. And if you can pop the detail of that informatic into the chat box for members of the public. Finally, Glenn.
Yeah, thanks, Sarah. Great statistics there. And as you say, there's a lot of activity. The majority of NHS activity goes on in primary care. The point you made, though, about the new extended roles is a really important one. And what we need to try and do from a George Eliot perspective is try and ensure that they're integrated roles. And there's we've got a great opportunity now, I think, to create careers which span hospital, community and primary care without people having to choose which sector they work in. So I think, doing that in collaboration with our primary care networks locally needs to be something as part of our strategic ambitions that we're updating now.
Okay, thanks, Glenn. Colleagues, we're running late, so if I can ask for brevity on the next few items, that would be great. So the first up is the mid-year review of trust objectives. Glenn?
I can be very brief on this one then, Chairman. So what we have here is the normal kind of half-year, mid-year stock take of where we are against the objectives that we set for the start of the year. We've done the usual, Jenny has done the usual RAG rating of the individual items. It's great to see the progress that's being made, and we heard about more of this morning. Despite the fact that we've obviously had the ongoing pandemic, we've obviously got very high levels of activity, which can, if you're not careful, consume us all with the here and now. But there's some really good strategic movements and a number of areas highlighted here. But I'm not going to go through all of them, but happy to take any questions or to pass them on to the relevant director.
Thank you very much, Glenn. Any questions or perspectives from colleagues? Keep up the good work, executive team. We had a really good update this morning from Catherine and Jenny on the progress at place in North Warwickshire. Some really exciting developments and deliverables that the team have put into place. We'll therefore move on to the winter plan, and this is the sign-off. We've talked about it a lot. Robin, what would you care to pull out?
Yeah, thank you, Chair. Just really to flag that this plan has come about from quite a significant level of engagement with clinical teams, staff on the wards, and other stakeholders, in discussion with ICB colleagues, and so it's been discussed far and wide already in terms of the makeup of the actions that we were proposing to take over winter. And in summary, the system bed gap that from the calculations done by NHS England for all systems for Coventry and Warwickshire come out at 239 beds, of which our proportion of that for George Eliot is 48 beds. But working on the key principles that we can't just keep putting more and more beds in to the hospital. Actually, the focus of the actions is very much about how we avoid admissions and how we expedite discharges and how we help to manage patients better in the community and things like virtual wards. So better use of the overall resources system-wide, just not within the acute trust. So in terms of surge capacity, that's remained open, 22 beds, and that's been funded by through the winter planning rounds already. We've had confirmation of that, and the other schemes that are listed in the paper form part of the plans in order to deliver effectively the remaining 26 beds of capacity. In actual fact, you see that the plans cover a minimum of 34 beds capacity to give us a little bit of a contingency plan to be on the safe side, and also that they seek funding of approximately £1.9 million in terms of overall costings, which is a discussion through the system through the ICB. I think the key point, again, I think it's been mentioned around communication. It's vital going forward, if this case is approved, that we communicate clearly, not only internally within the hospital, but with our system partners, of which this forms part of the wider ICB winter plan. So they've already had sight of some of these schemes in the makeup. And also, as has already been suggested, that the communication of these needs to be understood by the general public and members of the local community, so that everybody understands exactly what it is that we're aiming to achieve and how we're planning on doing that. And I'm happy to pause there, Chair, and take any questions.
Well, that's great, Robin, and some really good discussions again and updates on the virtual wards work that we're sort of pushing ahead with very strongly this morning. Any questions or perspectives to Robin? Julie?
Sorry, Chair. It's just one around communication. Great to hear that. But as winter goes on, things might happen. It's just understanding how we and the system will communicate so that the plan is dynamic to things that happen. So can you just explain for us how that will happen?
Yeah, sure, Julie. So we've already James Turner, I think, is on the call today for our head of communications within the trust. We've already started working up a communications plan around this. So how we communicate the initial work that's been done and making that understand as what it means to our staff and local community. And then what we will do is regular intervals throughout winter. We will then provide updates on that to say how not only how we're progressing, how those initial plans are taking shape, but also any updates on other initiatives that have come forward, because this is a dynamic level of engagement. So there will always be suggestions coming forward for things we could change or do differently. And it's important that we do communicate that out as we go through. So through a regular update comms plan.
That's great. I think part of the challenge is reaching all members of our community, not those who just, for example, listen to Glenn's Twitter account. Great value that is. Glenn?
I'm probably going to make a bit of an obvious statement, but I think it's one that needs to be said here. So it's great to see the number of beds or bed equivalents that we've identified as part of this plan. And indeed, there's some areas there where there's further numbers that I appreciate are hard to quantify. But that original gap of 48 beds, I think it's just worth reiterating that that's an average over a winter period, and there will be moments over this winter period where we're peaking well above that. So that's why we need, every bit of contingency of improvement in flow and process that we can possibly get.
Okay, thanks, Glenn. Any other questions or perspectives? Okay, Robin, good luck. What I think for me, the key message to members of the public is the way you can help us over the winter is to have your flu jab when you're offered it, to have your COVID jab when you're offered it. If you've got any symptoms, don't feel embarrassed to wear a mask in situations where you're coming into close contact with people. We've all got to do a good job as a community of looking after one another and shouldn't feel embarrassed in any way as to any steps we take to protect ourselves, our families, our loved ones and our communities. Moving on then to the sustainability strategy quarter 2 update. Jenny, what would you care to pull out of this, please?
Yeah, thank you. So I'll take the report as read. A couple of things to just specifically note. Firstly, the quarterly workshop that is part of our ongoing monitoring of the delivery of our green plan, and the updates that came out of that in terms of each of the focused areas that are part that make up our green plan. And you can see there that there's progress in each of those areas, and there's just a flavour provided for you in the report. And then just moving on to the bid section, you'll see that there's a number of bids that we've been following up. Probably just to pull out the public sector decarbonisation scheme, which has some very specific criteria, and so we're still looking at the best way to go forward on that, and we'll be looking to submit a proposal in the next round of bids there. And you'll see that there's a number of other initiatives where we've looking for specific funding on a range of quite innovative initiatives that we're taking forward. And then we continue to do a focus on our communications around good news stories and things that have been progressed. And you can see that there are a number of examples there. We have also produced two sort of animations, one which is a promotional piece around looking at why this matters, and that links into our theme around because we care, and that's really about sort of getting people involved in the sustainability agenda. And also we've done an animation for celebrating some of the good work that's going on across the trust of the examples of change that we're facilitating within a sustainability theme. Happy to take any questions, but those are the key things I'd like to draw out.
That's great, Jenny. If we can put those animations into the chat box, if possible, that would be great. If not, if we can pop them onto the website for members of the public to see. I'm also aware that Councillor Condicott in particular is quite rightly challenging us on our solar energy plans, and I know that work has taken a little bit longer than we hoped, but just to give some assurance that that work is ongoing. Any questions or perspectives to Jenny on the sustainability update? It is the future, and certainly within the foundation group down at Wye Valley, I think I'm correct in saying, Glenn, we will be the first trust probably in the whole of the country to be net neutral down at Wye Valley. And so we will, across the foundation group, be using the pioneering work they're doing and other bits of the group are doing to share sustainability knowledge. Glenn, do you want to come back in on that?
Yeah, to be fossil fuel free, I think is the position they'll be in, the first one. And I've said it a few times, and no one's come up to give me an alternative trust for that. So really good work there, and really good work here as well. So I'm sure we will continue to move forward rapidly on this as a group.
Okay, sounds a bit of a tongue twister to me, fossil fuel free. So we can all practice that. Thank you, Glenn. So we'll move on then to the report on safe nursing and midwifery staffing. Natalie, what would you care to pull out of your report?
Thank you, Chair. I think one of the priorities to pull out of the report is our focus, a continual focus on recruitment and retention, as we have all spoken about throughout today, workforce being one of our prime drivers to ensure that we can provide that quality care to our patients across the community. And we have continued to do this in conjunction with UHCW and with SWIFT in our Project 1000, and I was very delighted this morning to welcome 7 newly qualified nurses to the George Eliot, and at the end of this month I'm welcoming the first of our 9 international recruits coming in, and there's a trajectory and forward plan for that programme. I think alongside that, the report details where our vacancies are and how we are mitigating those on a daily basis. And it's just to provide that assurance to the board that staffing is mitigated throughout the day and through twice daily meetings with the senior nursing team. We do have the process of the Datex report to highlight any red flag events, and you can see within the report where that has happened and how we do review those, ensuring that no harm has occurred to our patients.
Thank you, Natalie. Any questions or perspectives to Natalie? Please raise a digital hand. So overall, Natalie, you're feeling obviously a little bit uncomfortable, but assured that we continue to be safe.
Yes.
Okay, super. Thank you very much. We'll move on then to the integrated performance report, including the finance report 2022-23 month 5. David Eltringham.
Thanks, Russell. So we continue to develop the new report format, and obviously now that contains the finance report, so that's very positive. The other thing I wanted to draw attention to in terms of development of the document was the publication of a public guidance document, which members of the public can now access in the same location as the board papers, which sets out the definitions for some of the data elements that appear in the report, and hopefully will head off questions of clarification and provide descriptions of those definitions which are useful to people. As you've already said, we had a board workshop this morning and we focused on 3 areas to ensure that we deliver as we head into winter. And we've also heard from Robin a few moments ago with regards to the winter plan. Our 3 areas of focus are around staff availability, reducing bed occupancy and reducing waiting times. And all of those things are relevant to the integrated performance report data and the things that we're about to hear about. So I'll just skip through a number of headlines from the report. So the financial position, our year-to-date deficit stands at £1.3 million, which is £0.8 million off plan. We are still forecasting recovery to break even by year end. The overspend is being driven by temporary staffing costs, and we know that that's an area that we want to focus on, which relates back to the point about staff availability, making sure that we're recruiting into vacancies, minimising the amount of bank and agency spend that we incur. And we also can see some deficits in income, or at least some opportunities to drive income through increased productivity. We're expecting some announcements anytime now around the handling of the transactions related with that into the second half of the year. And we know there's significant opportunity because of the position that we're in from a performance perspective. And we'll come on to that in a moment, for us to offer mutual aid to some of our partner organisations in other bits of the patch of the Midlands, who might not be in as good a position as us. So there's an opportunity for us to generate some income through that approach. Moving on to operational performance. With regard to emergency care, August was quite a difficult month, although obviously the height of the summer. A&E attends were slightly below plan, but we have seen an increase in the number of emergency admissions to the hospital, which tells us that the people that we're looking after are probably at the sicker end of the spectrum and require more time with us before we can discharge them. Having said that, our 4-hour performance continues to be relatively good when you compare it to other organisations. So we're in the top 3 pretty much consistently from a regional performance perspective, and in the national top 20 against the 4-hour standard. But having said that, our performance is still below 80%, I think reported here at 75.8, so a considerable distance away from the 95% 4-hour target. And I think it's really important that we are clear that we don't rest on our laurels with regard to that relative performance position, and we are consistently attempting to improve that number regardless of where we sit in the league table. One of the areas that we're grappling with in terms of that is length of stay. Our length of stay in the hospital is longer than we'd like, and we're looking at that quite carefully. We have a higher number of patients with a 21-day length of stay than we would like, and we know that we experience delays in discharge with somewhere between 60 and 70 patients at any given moment in time in the hospital who could be somewhere else if there was a package of care available for them. So a lot of work taking place to focus on discharge to assess pathways and the capacity that's available to support those pathways outside of the hospital. And of course, the other consequence of all of that is that our surge capacity remains open as a result, and that in its own right drives additional costs in terms of staffing. But that is the right thing to do, and we always put safety and quality first when we're focused on decision making around that. In terms of elective care in August, at the time of the report, there were no patients waiting more than 104 weeks. However, in September, we have had a 104-week wait, and Robin will brief out specifically about that issue at the end of my brief overview here, because there is a specific issue that the board needs to be aware of regarding that. We have no patients greater than 78 weeks, and at the time of writing of the report, we were reporting somewhere in the region of 70 patients at greater than 52 weeks, but that number is falling and is now in the order of 50, so some progress being made there. You can see in the report the levels of activity against the elective recovery programme weren't where we wanted them to be, reporting 87% from a financial currency perspective versus 104% for the month. Our real-time tracking shows that that's significantly improved, and in the week of the 25th of September, that was at 136%, so some improvement in recovery there, which it's important that the board recognise. In terms of cancer performance, some improvement there against the 62-day standard, so that's at 61.9%, but still adrift from the target. And we have a relatively small number of patients waiting for cancer care for longer than 104 days, 8 at the time of writing. I know that number is now significantly reduced, and each of those patients is case managed, so we know specifically what the plan is for those patients. The other thing I wanted to just speak about is mortality. And we've spent a lot of time on this in other environments, particularly in the deteriorating patient and mortality group. And I know the Quality Assurance Committee have also spent considerable time and energy on this particular issue. But do want to draw attention to the fact that while SHIMI is within expected range, HSMR is now an outlier, and we have undertaken some investigations and some background checks into all of that and reviewed the situation. We've got a clear action plan. Mortality action plan is monitored and governed through the committees that I've mentioned. And if anybody's got any specific questions, Catherine, I'm sure, will be happy to pick those things up. So in terms of a summary, it's a busy and challenging environment. We are focused on heading into winter on making sure that we retain our relatively good performance position, but not resting on our laurels, not becoming complacent, and constantly striving to drive the numbers up so that people wait less time for care, whether that's in A&E or for a planned elective procedure. And our three areas of focus are staff availability, reducing occupancy, and reducing wait. So that kind of summarises the performance position. I think before we go to questions, Rob, it's probably worth Russell just asking Robin to brief us about the specific issue relating to the 104-week patient.
Okay, thank you, David. Just so this patient was came through the ENT service that has been discussed here previously, as we have a service level agreement. We've had a service level agreement for the last few years, but certainly the last 2 years, that's been with UHCW, and they've been unable to provide us with the level of consultant and clinical cover in order to robustly run that service. And many on the gallery will remember back in April this year, a decision was taken to put in place an outsourced company at George Eliot in order to fill that gap as a response to maintaining patient safety and getting patients seen within that service because of the growing delays and issues. So the pathway for those patients coming through that service was that they would be seen at George Eliot and then transferred, if they required onward inpatient treatment or care, over to the service at UHCW. That was followed for this patient following a prolonged wait, whereby the patient then was not accepted at UHCW by their clinicians and sent back to be seen by a UHCW clinician at George Eliot. Now, on that basis, obviously, our first and foremost importance is making sure that the patient is seen in a timely manner, and therefore we've expedited that patient being re-seen, and they do indeed need treatment at UHCW. So the ICB are engaged in that discussion to ensure that UHCW expedite the care for that patient due to the period and the length of the wait for that individual. So that is being picked up at senior level in order to make sure that happens and that patient is not further disadvantaged. For us as an organisation, obviously that requires us now to review our position in terms of the ongoing service level agreement with UHCW. And I took a proposal through our trust management board last week in order to get a decision whereby we decided to serve notice on the service level agreement with UCHW. And I will bring an option appraisal paper back through our trust management board to decide on the future for the service moving forward. I think I would like to emphasise to the board and to the wider audience that obviously maintaining patient safety of patients in that service is of utmost priority for us. And in order to do that, we've been literally micromanaging every single patient that has been seen in that service through their pathway. And I can sit here and tell you now that we have only 5 patients now through the 114 that were seen and transferred over to UHCW. There's only 5 patients without a plan at this stage, and that is being worked on obviously on a daily basis. And we have a weekly meeting set up through the ICB with senior representation from George Eliot and and UCHW in order to man-mark these patients through and ensure they get their care in a timely manner through to obviously the completion of the service level agreement as we know it. And therefore I'll bring that back through Trust Management Board in order for a decision on that future service.
No, thank you, Robin. It's clearly very important, just not that we're ensuring safety for our patients, but also speedy care. I want to make a couple of points on David's IPR, but Glenn, you go first.
Yeah, just picking up that final point. Well done, Robin, for sorting it out. The most important thing is making sure those patients are treated quickly. What communication has gone to the patients on this? Is there any apology from UHCW colleagues that we can add into that communication?
At the moment, Glenn, it's been picked up. Helen West and Laura from the ICB, Laura Nelson, are working with these patients, and I believe a communication has gone to the patients from the ICB around the delays. I'm not 100% certain of the wording of that at this point, so I can't say the UHCW wording of the apologies for the delays, but I'll take a note, and I will get a copy of that so I can see what's been said.
Thanks, Ron. But just for the total avoidance of doubt, this is a failure of the process in UHCW that has let these patients down, isn't it?
Yes, indeed it is.
Thank you. Okay, so I wanted to add something to what David said in his introduction about our length of stay. Naj and the team in ED have done a phenomenal job at driving up our performance in ED, and our ambulance waits to amongst the very lowest in the Midlands, which is fantastic. The consequence of that is we are getting lots of intelligence conveyancing, and therefore lots of patients coming from, if you like, out of district. Members of the public, just so you're aware, that does make discharging disproportionately difficult for some of those patients, because organising packages of care when you're not in the local region is far more complex, and that then leads to delays of discharge and therefore an increase in length of stay. So I just want members of the public to be aware these issues on length of stay and discharges are not always within our local control, and quite often are a consequence of intelligence conveyancing and ambulances coming from us from out of district. But Naj and the team, and I know all of the support mechanisms around the ED team, are doing a phenomenal piece of work. Other questions and perspectives on anything we've talked about? Sarah Rastrick?
Thanks. A couple of perspectives and a quick question. I think from what we've just described with ENT, a comment, really, a perspective from our board. I'd like to thank the executives for some of the comments within the papers that acknowledge where we as a trust need to improve, and where we see areas within our own performance that we need to internally challenge and work on. So I think as a non-executive board member, I'd thank you for that candour in the papers, and I think that's really important to being a learning organisation and to moving things forward. So thank you. Those 5 patients, those 5 people that don't have a plan yet, Robin, is there a time frame for that to be completed? And then one more point not related to that, so I don't know if you want to.
Yeah, if I answer that straight away, literally it's daily iteration, Sarah. There's people looking at this day in, day out, and I know today there's been a further update from the team, so I'm expecting those 5 to have plans literally within the next few days, so we understand when they are being seen and where.
Lovely, thank you. And then the final was really to lend assurance from the Quality Assurance Committee's perspective that we have. We won't put Catherine on the spot now if others who are not members of that committee don't want to ask questions, but just to give assurance to the board that we have looked at SHIMI, HSMR, and I know the deteriorating patient group have added a lot before it even gets to the Quality Assurance Committee. So initially, these were things that we were talking about and we had hypotheses for, and we've moved now on from hypotheses to more evidence and plans to keep this in our observation, and I'm assured that Catherine has a grip and brings that to committee if that helps the wider board.
That's great, thank you, sir. But just for again clarity, Robin, the Chief Operating Officer over at UHCW should be fully briefed on this.
Fully briefed that we are reviewing our options based on the service or lack of service that's been provided. Obviously, waiting. What I've done so far is I have also notified the ICB that we are currently in discussion internally as to what our next options are, and following the formal reporting through board today will then allow me to progress those conversations to serving formal notice, and clearly I'll have a direct conversation with the Chief Operating Officer at UCHW as part of that cascade of our update to them.
Okay, if you could do that. I'm conscious of the fact that UHCW have a board meeting this week, so I think the earlier you can do that, the better, just so they're fully informed as well.
Okay, will do, thank you.
Any other comments on the integrated performance report, colleagues? Julie?
I've just got one quick one in the context of our 3 big moves and what we've been discussing a lot today. There was one initiative in there that I'd not heard of before, and just wanted to understand how that would help, and that was the Straight to Test initiative, and just wondered what the explanation and how that might help with waiting lists, etc.
Okay, I think that this is the idea of Straight to Test is where a patient is referred into a service, and then as part of the triage of that service, they then get directed straight to tests prior to them being seen in outpatients, and it effectively turns the outpatient into more of a one-stop shop, so that then patient isn't seen in outpatients and then sent on for further tests and then needs to be followed up. So it reduces the need for outpatient appointments for the patient, and would be or is a slicker service, and it's a model that's used in a lot of different services across the country, across acute hospitals.
Okay, thank you, Julie. Thank you, Robin. Okay, colleagues are happy to move on then. We will keep the pace moving and move on to the summary of ratified policies. David, what would you like to sort of pull out here?
Thanks, Russell. So take the paper as read, and matter of record that we've approved the speaking up policy.
Okay, super. Anyone want to speak up on the speaking up of ratified policies? Okay, duly noted. Thank you. So we move on then to the board assurance framework, the high and extreme risks only. David, what would you care to pull out here?
Natalie's going to talk to this, Russell.
Okay, great. Natalie.
Thank you. This is our quarterly review report, as it states within the report. This has been, during Q2, we've undertaken a full review of the BAF and triangulated that piece of work with the trust objectives, and formatted it under the objective headings as it states within the executive summary. The main areas of note and change are highlighted within the executive summary, but I think the main piece for me to highlight was that this has been a great piece of work undertaken by our Deputy Director of Quality Governance to triangulate all of our data and align it with our corporate risk register and our trust objectives.
Thank you, Natalie. Any questions or perspectives to Natalie on the board assurance framework? Okie dokie. I think just in terms of for members of the public, the biggest challenge I think we're facing as we enter the winter are the winter pressures that we've referred to a few times, and in particular the issue around staff availability. The workforce challenges we face, given how tired our workforce are in my view, the biggest challenge we have with a COVID spike coming back. So I would just sort of particularly emphasise those two. Okie dokie, thank you, Natalie. So we'll move on to the board effectiveness review. Sarah?
Thanks, Russell. So this report just formalises the process that we've been through for the annual board effectiveness review and the improvements that we're looking at making. So happy to take the report as read. Thank you.
Okay, thank you, Sarah. Any questions or perspectives on the board effectiveness review? Please raise a digital hand. Okay, team. So I think we're on to the voluntary services annual report. Back with you, Natalie.
Thank you. It gives me pleasure to present this positive report from our volunteers that have such a positive impact across our organisation. And this celebrates their achievements and gives us and the board the opportunity to publicly say thank you to our volunteers across George Eliot and our community.
No, absolutely. I mean, we are incredibly lucky at the George Eliot to have the volunteers that we have. I mean, the League of Friends at the George Eliot are outstanding. You know, we're lucky enough to have the previous chair and the chair on the line, I think, today with us. Not only in the support they give us on a regular basis, but also the sort of extraordinary support they've given us on the League of Friends canteen area as well as the other volunteers that we know in the broader community. Glenn, anything you'd like to add to this?
To reiterate all that's been said, particularly to emphasise some of the work that our volunteers have been doing to help patients who are waiting on our waiting list. That this is definitely NHS leading stuff, and you know, our team have been sharing that nationally. It's been great to see them get the attention for some of the innovation they put in place.
No, absolutely. Any other questions or perspectives? Okay, thank you, Natalie. So I think we're then on to the subcommittee chairs update. The first is the Quality Assurance Committee from the 30th of August and then the 27th of September. I'm conscious of the fact we're going to try and help ensure that all of these are written reports going forwards, which is a bit of a challenge given the timing of this board and the timing of the quacks. But Sarah, over to you.
We've picked up all the things that the Quality Committee wanted to bring to board. Notably, we did spend a significant amount of time looking at the workforce plans and recruitment within nursing and midwifery, and as I alluded to, mortality. And from the two meetings that you mentioned there, Russell, there was significant improvement and building on the discussions that we'd had at one, with further assurances and evidence being presented at the meeting that we had last week, especially regarding mortality.
Thank you, Sarah. And Sarah, it's been a few months now since you joined us in the position of Chair of Quality Assurance, and given your very considerable experience in different parts of the NHS, how are you feeling generally about quality assurance at the George Eliot?
Good question, Russell. I'm feeling that I took on the post at an interesting time. We've got Natalie with us as our new Chief Nursing Officer, but I have been very positive about the way that we view the evidence we have, looking from a medical, a nursing and a wider executive perspective. There is time for challenge from the non-executives, and I would thank Simone and others on that committee for that. We are, however, we're having a meeting soon, and I'll be working with Catherine and Natalie later this month to look at how we can build on what is good and make it even better. My aim would be that all executives out of their field of expertise and the non-executives on that committee would be able to give you and the public a very good, comprehensive layman's summary of the issues of quality concerns and what we're doing about it at the end of each of our committees. And when at times we have quite high level discussions, that don't quite drill down into the detail will be able to articulate things better as we move forwards, but very happy at the moment, and thanks to the executives that manage that. But as we pointed to in the papers today, there are some significant challenges that face us, but it is a delight to see that quality is championed not just by the nursing team and the medical team, but by the members of the executive from wider spheres that attend.
And again, just Natalie, it's still relatively early days for you, but would you endorse Sarah's observations?
Yes, Chair, and I think it's timely, after both of us being a couple of months and Sarah a month longer, that Catherine, myself and Sarah get together and we do that review. So as Sarah said, it is planned, I think, for next week. Okay, super. Thank you. Questions and perspectives to Sarah on her updates? Okay, I think members of the public can be assured that although mistakes inevitably happen in the high-risk world of healthcare, we as an organisation do promote civility, learning and openness in all of our activities. We'll move on then to the Audit Committee of the 27th of September. Julie, what would you care to pull out of this?
Just 3 points, if I could, please, Chair. So I'll assume read. We've talked a lot today around the North Warwickshire Pathfinder work around North Warwickshire Place and the readiness of our place to be embraced. So I won't mention any more about that. I would ask the board to just note some concern around mobilisation of our internal audit and counter fraud specialists who were a new appointment, and the actions being taken and how we need to work with them to ensure that we can bring forward their plan. Just the final point was around the fact that audit wasn't quorate this time, which is obviously very important. And I've made some suggestions in my report around that. That's based on the fact that although we weren't quorate, because I was, as chair, received notification that people couldn't attend in good time, I was able to receive comments from my fellow NED colleagues, which really helped with the discussion. It did lead us to go on to talk about the need to actually review the timing of audit, because we've had to change the timing of Quality Committee, and we're reviewing these now with our external partners, because obviously we have internal and external audit partners to consider in that. Thanks very much.
No, thank you, Julie. Any questions or perspectives to Julie? Okay, thank you for your hard work, everyone involved in that committee. And then the Improvement Board report. Glenn, from the 20th of September.
Thank you, Chairman, and thanks to Jenny for summarising it onto 2 sides. It's a very busy meeting which touched on a number of things. They're listed there, I won't go through them all. But particularly we try and look at an improvement story. We, in every meeting, we also take an update on the overall improvement programme. We also looked at sustainability last time, and the annual objectives mid-year review that we've just seen had its first outing at that meeting also. So lots going on there, but what this meeting does is coordinates all of that improvement work into one place, which is always good fun.
No, great, and incredibly important at the moment when the NHS is facing so many daily operational challenges, that we do always strive to continuously improve and be relentless in our desire for improvement. Any questions to Glenn on that report, please? Raise a digital hand. So we'll move on then to the Foundation Group Strategy Committee report of the 30th of August. Julie, anything you'd like to add to this?
No, not in particular, just to note that the value of working of the group in those areas that were outlined in the report, but also that the group heard about the update on Virginia Mason work from Worcester, and particularly around the improvement walks, which I think is something really interesting that they are actually taking part in, but no other points.
Okay, great. Thank you, Julie. Any questions on that report to Julie? Please raise a digital hand. Okay, so then just, I think we're on to any other business. Any other business from members of the board? Please raise a digital hand. So then finally we'll move on to public questions. If so, have we had any public questions made aware to us?
So we didn't get any submitted in advance, but David Carr's got his hand up.
No, that's great. David, welcome.
Thank you, Chair. I just wonder if one of the team would put some advice to the public on what vaccinations are available to the public at the George Eliot Hospital, how and where. Thank you.
Great. Thank you, David. Gertie, do you want to cover that one off for me, please?
Yes, I will. Thank you, Chair. We have a 6-day-a-week vaccination service running out of Coombe House, which is a small building to the front of the site, opposite the main entrance. It provides, at the moment, for members of the public, it is open for COVID vaccinations. You can either book through the national booking system, or members of the public can walk up and attend that on spec. We hope to have finalised the details of being able to provide flu to the public, but I would imagine that will take another week or two to finalise some of that contracting information. And as Russell's already said, I'd strongly encourage everybody to have both vaccines as soon as possible.
Absolutely. Thank you, Gertie. And any other questions for members of the public? Okay, the next board meeting of the George Eliot board is in December, the 6th of December, but we do have the 3 board meetings coming up in November, details of which will circulate beforehand. But in the meantime, can I just again reiterate what Gertie just said? Please do have your vaccine as soon as you're able. Have a double jab if you fancy. Left arm is for COVID, right arm is for flu in my experience. And look after one another. It's going to be a very, very tough winter. I want to just ensure that members of the public realise just how challenging things are going to be in the run up to winter. And I want to, in advance, thank all of our frontline teams and all of our behind the scenes team who work extraordinarily hard to deliver the healthcare that the people of North Warwickshire deserve. Take care, everyone. Look forward to seeing you maybe at the 3 board meeting, but definitely at the George Eliot meeting. Thank you very much. Take care. And for board colleagues, can I suggest we have a 10-minute break and we get together for the confidential board at 3:15, and I'll try and save you some time. Thank you.